Our next guest is new to the ResusX team, and her name is Dr. Sarah Crager, and she's coming to us all the way from the West Side. What is up?
How's it going? Los Angeles. Earlier
Right
in the
on.
morning here. Warmer too.
And originally we wanted you to speak at 7 a.m., I think, and you're like, what? That's going to be, yeah, not going to happen.
2, 4 a.m.
Well, thanks for being
Nope.
here. Thanks for being here, especially so early in the morning. And you're going to be talking about something that I love, and that's the Sick DKA patient. I love these patients because they're usually pretty straightforward patients. They're sick, they're better, and you feel good, but they can occasionally be very sick, and that's what you're going to be talking to us about today, right?
Absolutely. I love these patients because I am a, EM intensivist, but I am one of those instant gratification intensivists. I do not like hanging out in the NICU, rounding for 5 hours, talking about tube feeds and how the patient will get better over the next 7 weeks. Yeah, not super into that. I like DKA because they're sick. They can be really sick. They can be really complicated, require some thinking, but if you do it right, you can make them better and pretty fast. So,
Fantastic.
the Sick DKA patient.
All right, take us away.
All right, off we go. Screen should be sharing. Beautiful thing. All right. So, as with almost any lecture I gave, my residents will tell you that I usually start with the how to think about the pathophysiology. And I am not doing this to torture you. I am doing this because I firmly believe that anything with critical care, anything with resuscitation, the goal is not to memorize an algorithm. The goal is to know what you're doing so you can think about the individual patient in front of you and figure out what to do with them. But if you're going to do that, you have to, step one, understand what's happening. Fortunately, this part for this lecture is pretty short. We already understand a lot of this. And the main thing that we already understand, but I find myself needing to repeat over and over and over again every time I do a DKA resuscitation, is DKA is not about the sugar. Now, this is obvious to all of you. The problem is that you need to work with a big team of people. And in order to do this resuscitation right, you got to get them all on board with the idea that you just don't care about the sugar. I mean, really, you just want to make sure it doesn't go too low too fast. Otherwise, not about the sugar. And really, I think the best way for me to think about, conceptualize, and also talk about DKA with my team is this concept of a supply-demand imbalance. Just like, an MI. When you have an MI, we talk about it as in you have an oxygen supply-demand mismatch. In DKA, it's the exact same idea, except rather than an oxygen supply-demand mismatch, we have an insulin supply-demand mismatch. Now, the obvious cause of DKA that everybody thinks about, that's super straightforward, of course, is a decreased insulin supply. Now, whether this is your pancreas is broken and you have a medication problem, you never got started on your insulin, you didn't know you needed insulin, you forgot your prescription, whatever it is, that's the super obvious one, right? Somebody comes in, my insurance got canceled, I couldn't get my prescription, whatever, stop taking the insulin, decrease insulin supply, voila, DKA done. Now, the thing is that not only is this the obvious problem, often the patients who are the sickest, that's not their only problem. Often, those guys have a second problem because it's not just an insulin supply issue, it's also an insulin demand issue. And when I say insulin demand, what I really am talking about is what physiological stress does to what your body needs in terms of insulin. And so generally, what's often happening here is that if your patient is having an ongoing physiologic stress, it's really driving aggressively that demand for insulin. And so your insulin supply may be not great, but could be worse. But if you really hit that insulin demand hard, you can get so out of balance here that you end up in DKA. So how does this work functionally? Well, the issue is this, that no matter whether your problem is you just don't have enough exogenous insulin, endogenous insulin, whatever it is, you're not getting enough insulin in, it actually does almost the exact same thing as what happens when you have a physiologic stress. They activate this common final pathway, which is that this little enzyme lipase likes to chug out free fatty acids from triglycerides and ultimately create a ketoacidosis. Details go back to biochem. We don't need to talk about it right this second. The important piece is this, that if you aren't getting enough insulin, pancreas isn't doing its job, you're not taking your meds, obviously you drop your circulating insulin, right? Okay, well, that drops your intracellular glucose. Your cells think they are starving to death, and they activate lipase to switch your metabolism into ketosis. However, watch what happens when you get enough physiologic stress, when you ramp up your insulin demand. Now, whether that's from sepsis, whether that's from an MI, whatever it is, your physiologic stress response is actually really what's driving a lot of the ketoacidosis here, as opposed to simply the hyperglycemia. Why? Well, what happens when you have a physiologic stress response? You ramp up cortisol production, you ramp up epi. What do those two things do? Well, it turns out they activate the very same enzyme. They have direct activation intracellularly where they start doing this thing as well, where they upregulate, where they're chugging out more free fatty acids and propagating ketosis. Then at the same time, something else is happening independently. This stress response induces tissue insulin resistance. It ups it. What does that do? Well, obviously, it further decreases the intracellular glucose that then by itself further upregulates lipase, and then you get into this cycle. And so it's often the physiologic stress that's really important here because it's really a lot of what's driving the acidosis. And as we said, DKA, it's not the sugar that's the problem, it's the acidosis. And it's also important to understand this because what kinds of patients can mount a stress response and who can't? For example, this has a lot to do with why patients with type 2 diabetes, especially the young ones with type 2 diabetes, they will still get into DKA. Why? Well, it's not like the type 1 diabetics where they just literally don't have any insulin hanging around. It's because they are young and otherwise healthy. They can amp up that physiologic stress response pretty aggressively. And so they can get super out of balance with that supply-demand issue, pushing themselves over into DKA. At the same time, those little old people, the little old lady who we always talk about like in a trauma situation, that she may not be tachycardic or hypertensive because she doesn't have a super robust stress response. Same thing. That little old person doesn't have a great stress response. They may end up not in DKA, but in HHS, for example. So it's important to sort of think about this as not just an insulin supply problem. This is also an insulin demand problem. And what is driving it? And do you have a physiologic stressor driving this process? Because if you do, if there is an ongoing physiologic stressor, if the patient's infected, if they're in shock, if whatever it is, you're going to have a much harder time fixing their DKA than if it's just an issue of they didn't have enough insulin, you replaced it, you're all good. So, item number next, arriving at the correct diagnosis. Now, when I was first learning about DKA, I was like, oh yeah, totally simple. You have the D part for diabetes, sure, glucose is high. You have the A part for acidosis, check, diabetic ketoacidosis, done. Turns out not that simple. While it may seem straightforward, not so much. Why? Well, because you can have situations like this. Just because you have a patient who has a high glucose and a low bicarb, they might not have DKA. The other day, I had a little old guy come in and he got called up to the ICU. They were like, yep, we put him on a DKA protocol. His anion gap was 28 and his glucose was 800. And we were having some belly pain and vomiting, but it was non-tender. So we think it's just with the DKA. So they put him on a drip and admitted him to the ICU. Turned out not so much. Turned out that the guy was having mesenteric ischemia, giving him the non-tender abdominal pain. He then progressed to lots of ischemia, giving him the lactic acidosis. That physiologic stress didn't even put him into DKA because he was little and old and couldn't mount a stress response. And so he just had a lactic acidosis and a super high glucose, and there we had it. Now, why is this important? Because if you diagnose somebody with DKA who doesn't have it, and you start them on an insulin drip, not a big deal, it's fine. The problem is you have just missed whatever's actually wrong with them. So that's problem number one. Problem number two, you can have a patient who has a normal glucose, a normal bicarb, but they do have DKA. Doesn't mean that DKA is absent. So what about this patient? Actually, it was the same day. I just happened to have these two patients. I had this guy. ED called me about him. They were like, look, we're admitting this guy to the ICU because we just can't get access. He has a centerline because he's just vomiting like crazy and you just can't keep anything down. We think he's really dehydrated. So here's the deal. 58. history of some alcohol use, history of diabetes, came in with abdominal pain, and just was like, I'm just vomiting like crazy, vomiting over and over and over again. Turned out his lipase was really high. And, when they called me, they were like, yeah, he's on some weird diabetes meds, but we don't think that this is DKA. I mean, his sugar is not even high. His bicarbs are normal. We think he just needs like fluids for his pancreatitis and whatever. Okay. So they admitted him to me for vomiting and pancreatitis and whatever. And like the bicarb was normal and the sugar was okay. So he can't possibly have DKA or weight. Turned out, if you actually calculated his anion gap, which our lab there doesn't do, but is always a good idea to do, his anion gap was 33. And the way that I like to think about an anion gap is this is a if there is smoke, there is fire situation. Because if you have an anion gap, you must assume that you have an acidosis somewhere in there. But the resident called me up later because I think he read my ICU note and he was like, how can this patient have DKA? Because, the acidosis part wasn't there. Well, here's the deal. And this one is missed all the time. Let's say we have a patient and they have some kind of process, for example, DKA, that's causing them to have an anion gap metabolic acidosis, which is dragging their pH downwards. But what if, just hypothetically, at the same time, they have an equally robust but opposite direction process where they now have a metabolic alkalosis that is more or less equally robust as their metabolic acidosis due to, or in this case, vomiting like crazy, because if you vomit badly enough and are dehydrated enough and have enough contraction alkalosis, yeah, you can get a pretty significant metabolic alkalosis if you've been vomiting that much. What's that going to do? Well, that is going to drag your pH up. Now, what happens if you have these two things going on at the same time? Well, they're kind of going to cancel each other out and your net pH is going to look normal. Your net bicarb is going to look normal. And so this patient is actually going to have two very significant acid-base disturbances, but a normal looking bicarb and a normal looking pH. That is, until you fail to treat the DKA and you give a bunch of fluids, especially normal saline, and you resolve the metabolic alkalosis, and then all of a sudden, now your pH and the DKA reveal itself. So let's say we've gone through all that, and we have now concluded that the patient has DKA. They definitely have DKA. It's not DKA. It's not DKA. That's what they have. Wonderful. However, it's not quite so simple yet, because I think the problem number next that always happens is that once we've diagnosed somebody with DKA, and this happens all the time, we're in the ED, you call up the ICU and you're like, I'm admitting them to the ICU for DKA. Ta-da! And now, as the person admitting the patient, I have it in my head that, okay, this patient has DKA, that's the problem, that's the reason for ICU admission. But the problem with that is that often DKA, I find to be a red herring. Because once we diagnose them with the DKA, we just get real focused on that, especially if they're profoundly acidotic. And despite the fact that we all know that we really need to be hunting for that physiologic stress, you cannot get distracted by treating the DKA. And this is sometimes what I'll do, which I don't do all that often, which is I'll just go on a fishing expedition. Like if they're in bad DKA and I'm giving them a ton of insulin and I'm just not getting anywhere, this is when I have a little old person. I'm like, I don't know. I'm just going to scan everything. I'm going to check everything because something is wrong with you. Maybe it's just the DKA, but I need to make sure it's not. Because the other major pitfall here you want to avoid is this chicken egg problem that I think happens when you get really focused that their primary admitting complaint is DKA. So, for example, I hear this all the time where I'll have somebody admitted to me with DKA and altered mental status. And the idea is that the DKA is causing the altered mental status. Now, that might be true, but it might also be true that something caused the altered mental status, which caused a physiologic stress response, which caused the DKA, and your causality is in the other direction. And for example, in this particular case, if somebody is trying to sell me on the idea that this patient's altered because of their DKA, their osms better be high. Because if their serum osms aren't high, then I'm not buying it. I need to go hunting for another cause. All right. Next item, this is the sick or not sick part. You're doing this assessment from the very beginning, but this is an important assessment for me with DKA. Because what I'm about to tell you in the management part is that I am not a huge fan of putting all patients on the DKA protocol. That being said, I am also not a huge fan of trying to manually manage 7 DKA patients at a time. And so often what I will do is look at this patient and try and sort out, do I think they're sick enough that I actually need to manually manage them? And like all good emergency physicians, my first test is the eyeball test. Do they really look that sick? That one's easy. We all know how to do that. If they get a D- on the eyeball test, I'm probably just going to manage them manually. But then I start thinking about this physiologic cliff idea. And I think about this with all kinds of conditions, not just DKA, but it really applies here. Where is my patient on this physiologic cliff? I'm trying to get them to take a flying leap over to the other side and get recovery, but they're kind of teetering on the edge. Are they almost falling off? Do I have some space? What's going on? Now, you may have noticed that in the diagnosis part, I didn't talk about ABGs. And I love ABGs, don't get me wrong, but in diagnosis of DKA, that's actually not really the most important test. But I still do get an ABG or VBG when I'm evaluating a sick DKA patient. Why? Because it's the ABG that can help me figure out this concept of where are they at on this physiologic cliff here? How much room do I have to maneuver? And this is where we get into the idea of appropriate compensation for an acute metabolic acidosis. So here's the deal, right? This is the patient's ABG. They have an acute metabolic acidosis. Now, we all learned a very long time ago a formula called Winter's formula, which hopefully you have all forgotten now. I mostly have forgotten it. And even aside from that, I do not like to do math in the middle of the night. I just don't trust myself to do math in the middle of the night. So there's a much easier way to just visually estimate whether your patient is more or less compensated. It is very simple. Many of you probably know it. All you do is this. When you have a patient with an acute metabolic acidosis, you ask yourself the question, is the CO2 equal approximately to the last 2 digits of the pH? And if so, voila, your patient is appropriately compensated. And it turns out that this method of doing it is just as good as Winter's formula. People have actually studied this. If a nephrologist ever really, really wants you to do math, you can simply refer them to their own literature because they've checked it's the same with or without math. So I use this to just very quickly eyeball, is my patient more or less compensated? Now, what about this? What about this ABG? So this patient has a pretty profound metabolic acidosis, and my CO2 is not equal to the last 2 digits of my pH. But here's the thing. How low can somebody blow down their CO2? Not much more than 10, right? I once had an ABG and I saw 8, which I was pretty impressed with. But physiologically, it's pretty hard to get your CO2 much below 10. And so the reason that me and most other resuscitationists start getting really concerned at about a pH of 7.10 due to a metabolic acidosis is because that is telling me that my patient is coming up right at the edge of that physiologic cliff. Because we have no more room to maneuver. We have no more room to compensate. They are compensating as hard as they can. So like in this instance, this patient doesn't have a respiratory acidosis. They're hitting a wall. They can't compensate anymore. So I am concerned about this patient. Why? Because I'm concerned that they're about to do this. So let's take a look at this patient. What's happened here? Well, your bicarb is still sucks. It's still 3. Your metabolic acidosis hasn't gotten better, but now you have developed a respiratory acidosis. And now your pH really, really sucks. And what that is telling me is that my patient is now sprinting towards the edge of the cliff, and I do not have a lot of time to fix this. Now, unfortunately, when anybody sees a patient with this ABG, with this kind of sort of superimposed respiratory and metabolic acidosis, and their patient's breathing hard and they look terrible, what is your first instinct? Well, it is to intubate them. Unfortunately, that's a terrible idea because intubation is an excellent way to push them right off that cliff. Intubation, bad idea. Why? Well, here's why. Let's take a look at what happens to your delta pH, to the change in your serum pH in relationship to your minute ventilation. Okay, so as we all know, as your minute ventilation goes down, your serum pH goes down as well, right? Your CO2 goes up, serum pH goes down, super easy, right? Okay, there's a very important thing here. There is a very important inflection point in this curve. And what this means is that if you have a patient who is, say, above this inflection point and you decrease their minute ventilation a little bit by, I don't know, giving them a little fentanyl, well, their pH will drop some, but not a ton. What if you really decrease their minute ventilation? Like you decrease it beyond that inflection point, for example, when you paralyze them to intubate them and make them apneic. Now watch what happens to their pH. It now drops precipitously. Now, if you start out with a pH of 7.2, not a big deal. But if you're starting out with a pH of 6.87, your patient is going to code. No bueno. So, intubating these patients is very, very dangerous. If you are forced to do it, you've got to figure out some way to do it where you minimize or eliminate apnea time. Exactly how to do that is another lecture, because what I would like to convince you now is that even if you get away with doing it, even if like team high five, patient intubated, not dead, yay, your problems are far from over. Why? Because even once you've intubated them, you're now going to have a nightmare of a time keeping up with their mechanical ventilation. Because the thing is, a patient by themselves spontaneously breathing can achieve a far higher minute ventilation, can move much more air in and out, can blow their CO2 way farther down, just breathing spontaneously, than you can on a ventilator. And so you actually may just make the entire situation worse, especially if they have any history of obstructive disease, COPD, asthma, you're going to be in trouble. And so try really, really, really hard to avoid intubating these patients. You really don't want to do that. Now, what if you are in that situation? The patient's looking kind of crappy, the pH is coming down, you haven't managed to fix the bicarb yet, and now like the acidosis is getting worse because the CO2 is coming up. Okay, I want you to all stifle your just instinct that we all have as EM physicians to intubate that patient immediately, and instead, BiPAP man to the rescue. This is a great time to use non-invasive positive pressure ventilation. Now, the caveat here is don't wait till the patient is so altered that they can't protect their airway. That's the wrong move. But if you get that ABG and that CO2 is creeping up, or you're just watching the patient, they're working really hard, you're in trouble. Start BiPAP early, because all you need to do is support their work of breathing, is to support them blowing off all that CO2 until you can fix the acidosis. And if you're doing it right, it shouldn't take that long. You really want to avoid intubating them. Now, you may be saying, yeah, but aren't these patients vomiting? So yeah, a lot of them are vomiting. I've at this point given them a lot of Zofran for just this reason, but what we don't need is aspiration on top of all of our other problems. So if your patient is vomiting or looks likely to vomit, instead of BiPAP man, we'll just make him high flow nasal cannula man. If you put the flows up high enough, maybe that'll give him a little extra support for work of breathing. Now, DKA management. The main thing that I would like to say about DKA management here is short and sweet, which is DKA management does not consist of clicking off the checkbox to start the DKA protocol. That, or at least, is not what you should be doing. Now, to be clear, I do this for most of my not sick DKAs, because most DKAs come to the unit, and if they're not that sick, I just need to cognitively offload. But at the same time, why do DKA protocols exist? Do they exist because it's the absolute best way to manage sick DKA patients? No, they exist, one, because doctors are lazy and they don't want to get called every hour, and two, because whoever comes up with them also thinks that doctors are stupid and we better come up with a protocol for the least common denominator person. Now, hopefully we as resuscitationists are not that person. So as an alternative to the follow DKA protocol for every sick DKA, I would propose the following alternate strategy, which I like to call the do thinking strategy. This involves you knowing things about, for example, acid base and fluids and all kinds of things. And so I, for me at least, don't really always follow the protocol, because I find that with the protocol, if the patient's really sick, you either one, end up not giving enough insulin to correct the acidosis, and then they get sicker, and then they end up increased work of breathing and they can't keep up. Two, You give enough insulin to correct the acidosis, but then you end up giving huge volumes of fluid. All kinds of other things can go wrong. Now, whether you're on the protocol or not, I would say that the very number one first place error I see in sick DKA patients that I have done over and over again, I'm sure all of you have, and everybody I see, it's really hard to avoid this, despite the fact we all know about it, is the potassium. And we all know this. We all know we got to replete the potassium. But most of the time when I get called on a patient who was doing okay and then wasn't, it was because we were not aggressive enough. So this is one of the few times that I just straight up put in a central line. If it's a sick DKA patient and they're sick enough, I'm manually managing them, I just put in a central line. These patients have terrible access. Through a central line, you can give your potassium at 20 milliequivalents per hour. And some places will even let you do it at 30 through a central line. It means that you don't have to interrupt your insulin for all the fluids and all the other stuff. I load these patients with antiemetics the minute they get to the ED, even if they're not vomiting, because I want to give them PO potassium. And I maybe want to have the option of doing BiPAP later. Go nuts with the potassium. Like, don't be giving like 20 milliequivalents or like 40 milliequivalents if it's even on the low side. I'm talking like 100 milliequivalents. Get comfortable with it. That is where you get behind. And by the way, don't forget about the MAG, because if you have a MAG of 1 and you're trying to replete the K, it's not going to work. Now, I have to briefly address the bicarb issue. There is much angst over that issue. And I feel like the proportion of angst is actually kind of not really relevant to the complexity of this question, because here's the thing. I think that we need to keep our eye on the goal here. Now, our goal in DKA is not actually to fix the acidemia, right? That's not really it. Our goal is to fix the acidosis. Our goal is to fix the process, the ketoacidosis that is causing the acidemia in the first place, and transiently giving a push of bicarb that makes the pH a little bit better for a minute isn't really helping you. And in fact, it's hurting you. Why? Well, how are you going to fix the acidosis? How are you going to fix that process? By giving a bunch of insulin. What is going to stop you from giving insulin? What is going to limit the aggressiveness with which you can give insulin? Your K being low. You know what's going to lower your potassium? Giving a bunch of bicarb. So giving bicarb is kind of shooting yourself in the foot. It doesn't directly fix your ketoacidosis, and it may hobble your ability to continue to aggressively fix the whole problem you're trying to fix in the first place. Every now and then, if I'm in a situation when I'm like, okay, I maybe need to very transiently fix the acidemia before I fix the acidosis, like if I really have to intubate the patient and I maybe give them a little bicarb so they don't code, but I know it's transient, but I try not to, because at the end of the day, you're just not helping yourself. However, there is a time during these resuscitations when I do give bicarb. So let's take this patient, for example. We have this patient who came in with really bad DKA. They were on insulin for 12 hours, gotten a ton of insulin, and they've also gotten 8 liters of IV fluids. They're looking better. They're perking up. Everything is wonderful. And ta-da, we've closed their anion gap. So you're like, okay, cool. We'll transfer this patient to the floor. But then the medicine person calls you and is like, not cool. What are you talking about? They still have a pretty bad metabolic acidosis. Now, problem 1 here, that's our bad. We probably just gave the patient 8 liters of normal saline. Normal saline is not my favorite fluid. Not very helpful. Don't do that. LR, LR, and LR. However, there's another problem here that is going to happen, and is actually most likely to happen in your young, healthy patients with good urine output. What is it? Well, problem number 2, the reason you're probably going to see this non-GAP acidosis developing as your GAP acidosis is resolving is the following. When you're in DKA, you're using your bicarb to buffer your ketoacidosis, right? So your bicarb accepts your proton, off you go. But now as the DKA is resolving, what you're doing is, as the DKA is resolving, you're metabolizing your keto acids and you are regenerating your bicarb. Wonderful thing. What if now, instead of using your keto acids that way, you're peeing like crazy because you got 8 liters of fluid, have good healthy kidneys, you're peeing like mad, and you're peeing out all those keto acids in the urine as sodium salts. Well, now what happens? Well, now you can't regenerate your bicarb by metabolism of those keto acids. And so now you've lost potential bicarb. Now, this is when I give bicarb because we now have two problems. We've lost potential bicarb. We have a hyperchloremic metabolic acidosis. Now, bicarb will fix my primary problem. And why do I even want to do that? Well, turns out acidosis by itself as a physiologic stress causes insulin resistance. So what I don't want to do is get the patient off the insulin drip, close the gap, send them to the floor, and then do this all over again in a couple hours when the acidosis itself causes insulin resistance, and back we go into DKA. So at this point, bicarb, probably a cleverer idea. Last thing, fluid administration. So we're going to talk quite a bit about fluid administration later in my lectures tomorrow. But in brief, for fluid administration in DKA, this is another place where people can really screw it up. Now, you got to restore their intravascular volume status. Giving massive amounts of fluid is not something I normally do in ICU patients, but is something that you often do need to do in these patients. However, because you're often giving a lot of fluids, you need to be aware of a couple things. One, please do not worsen their acidemia by giving them 10 liters of normal saline. It's very unhelpful. Two, do not cause volume overload. Just if they're not peeing, they don't maybe need as many fluids. And lastly, don't worsen cerebral edema. And as we'll talk about in the fluid lectures, in order to do this, you got to divorce the fluid quantity from the fluid composition.
Fantastic.
So we are out of time.
Thank you so much, Sarah.
Interesting. Good luck.
Really appreciate that. Thank you so much. We're going to bring you back a little bit later.